Good afternoon, and welcome to Health Leaders, the Winning Edge program, a series of webinars touching on the topics and strategies that you need to know most. My name is Luke Gale, Revenue Cycle Editor for Health Leaders, and I will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Defeating Denials, sponsored by Aspirion. Thank you to you and our audience for participating, and to our sponsor for making today's program possible. Before we get started, for those of you participating in the live program, I have a few housekeeping details. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all of the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find the resources list for today's webinar on the upper right of your screen. Here we have listed the webinar slide deck and some additional materials for you to download, along with a registration link for future The Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of our program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our panelists for today's discussion. Jim Bonsack, Chief Strategy Officer and Client Officer for Aspirion, Keisha Lewis, Executive Director of Integrated Authorization Services, Wellstar, and Brad Olson, Vice President of Managed Care for Mercyhealth. Thank you for joining us, and with that, let's get into our discussion. And first, can you tell us a little bit about yourself and your organization? And we'll start with Keisha, please.
Hello, everyone. Thank you for having me. My name is Keisha Lewis. As Luke shared, I am the Executive Director for Authorization Services with Wellstar Health in Georgia. I've been in healthcare for many, many years. I pride myself on being a revenue cycle girl, started frontline, and have explored multiple areas. I am currently, again, with Wellstar. It's one of the largest health systems across Georgia and the largest provider of our charity care in Georgia as well. So when we say we serve the community, we truly do that. Wellstar medical centers, our health parks, our medical offices, and other facilities include, but are not limited to 11 hospitals. We have about 2,700 plus licensed beds. We have 5 health parks, 27 urgent cares and locations, and over 33,000 healthcare professionals. So we also pride ourselves in being a organization where we have been a great place to work, and pride ourselves in being more than healthcare, but we are people care.
Thank you, Keisha. And Brad, would you like to go next?
Yeah, absolutely. Thank you for allowing me to be part of Health Leaders today and be part of this panel. My journey started in healthcare in 2001, so I've been serving in the healthcare arena now for 25 years, all within the business side, finance, accounting, and then in 2005, I made the journey into managed care. I've thoroughly enjoyed the managed care transition, and actually we have worked for many large systems through my 21 years of managed care. But I've worked for the providers, I've worked for payers. I had a nice stint with a large payer back in 2012 to 2018, and then made my way back into the delivery system side in 2018. And then I've actually been with Mercyhealth now for just going on about 2.5 years. It's a wonderful organization, 7-8 hospitals in northern Illinois, southern Wisconsin. We employ over 800 physicians. We have 9,000 partners that work for the organization, located in 12 counties. We have a very large MFM delivery provider delivery system, highly acute trauma areas and trauma systems. And then we continue to grow and have been expanding our services into the western part of northern Illinois as well. So we've been ranked on the top 100 hospitals for last few years and have lots of accolades along with Malcolm Baldrige awards and things like that. So appreciate the opportunity to be here today and talk to the members.
Thanks, Brad. And last but not least, Jim.
Yeah, how are you guys? Yeah, thanks for having us and organizing this. Jim Bonesock, I am the Chief Strategy and Client Officer for Aspirion. So I've got responsibility for where we're going, what we're building or buying with product and M&A, and then how we work with our current clients and prospective clients and bringing those solutions to the market. The majority of what we do is focus on the largest health systems in the market, focused on those areas where complex claim types, including denials and underpayments, out-of-network claims, No Surprises Act, all the way to MVA, workers' comp, VA, TRICARE, out-of-state Medicaid. Generally, if we need tech-enabled services to support niche areas of the revenue cycle, that's where we fit best. So we are happy to work with, I think it's now 18 of the top 20 health systems in the United States. For myself, I've been in this space for 27 years, I think is the count now. Early on, Ernst & Young, Deloitte, turnarounds, health systems, Jackson and Miami, implementation of Epic at Kaiser when it first rolled out. So I've had some experience there, and then spent the majority of my career building products, setting strategy, and doing M&A. So I've been here for about 3 years in that type of role, and we're excited to kind of talk to all of you today.
Thanks, everyone. Really excited to have you here and really appreciate your time. And with that, we'll move on to the first question. What is the single biggest driver for denials today? Is it clinical, like medical necessity, or administrative, with prior authorization or eligibility? How has this changed in recent years? And Brad, can we start with you?
Yeah, absolutely. Thinking through some of these questions prior to talking to you all today, there really isn't any one single area, just to be honest with you. I think that it tends to be medical necessity, it's authorization, it's administrative, it's medical record needs. You go down to just the basics of, what procedures are authorized, not authorized, in a facility, not in a facility, office only. I mean, there is so many rules that plays into a denial. I actually am not smart enough to know how many denial codes there are nowadays, but I know it's in the couple hundred. So from that sense, I don't think there's just one single biggest driver. But what I would tell you, and I think probably what's so important in the changing environment is when I was at a payer, it was very important that we were evaluating on an annual basis billions of dollars of recovery dollars. And so when you think about from what the payers are doing, and obviously they're working for their customers, for their clients, and they're making sure that they're doing the best thing for their customers and the clients and those members. But on the delivery side, where I've been now for 20 years as well, it's very important that we have the right tools in evaluating all of the administrative denials continuously. And one of the things that I've really seen transition over the last, say, 4 to 6 years is this ability to incorporate AI on the payer side so that they're matching what is the provider's doing, what is the provider doing, and what is the hospital doing. And they're connecting that service between the hospital and the provider. And they're saying, is that ER level the same? Is that if that ER level is not the same, then where can that denial come in? And now we're not talking about people that actually are going and digging and looking through those records. This is automation, right? This is AI. They're just looking, they're taking these two claims, matching that up, rolling that down to the next level. And then the providers are having to come back in there and saying, no, we don't code the same way as the physician, and we need to make sure that the documentation, regardless if it's on the physician side or the hospital side, is matching to make sure that the reimbursement is elevated to the services that was provided. So I think honestly, every provider, delivery system, individual provider, small system, large system, we're always waiting every May, June, we're waiting for those provider manual updates letters to come to our door and say, hey, here's what's changing. And then we're all preparing and digging in to try to get ready to combat that before the new year.
Thanks, Brad. Appreciate the answer. Keisha, where are you seeing the most denials at Wellstar, and how has that changed in recent years?
Yes, I agree. Everything that Brad was sharing, especially in an authorization world, everything that you're saying, that's my life every single day. For our organization, I actually did a little bit of digging in preparation for this, and our top drivers for our denials for HB for the hospital billing are actually, it was non-covered services. We had coding errors, eligibility issues, missing claim information, and requests for additional documentation that we were receiving. And over the course of the past 2 years, we have really been holding steady with both our denial rate and the underlying reasons for these denials. And this consistency just really suggests that while like our processes may have stabilized, there still remains like the key areas of focus that require the ongoing attention to reduce these preventable denials and just improve the overall financial performance. So.
Thank you, Keisha. And Jim, what are you seeing in the denial space?
Yeah, what they said is in fact true. We obviously see a wide variety across the United States by different organization types and track it pretty religiously. The most troubling trend has not been, it's the denial rate overall has continued to climb, and I think you can attribute a lot of that to what Brad mentioned is the deployment of technology in this broad category of payment integrity investments that these payers are doing. I mean, they are using more sophisticated technology to pattern recognize and to use effectively odds charts to deny certain levels of claims based on an error rate and belief that, a majority of those won't get responded to if you don't have enough staff. I think the troubling thing that we're seeing in particular is the payers stating we're going to reduce the number of authorizations required, but in turn, all of they're doing is increasing the amount of medical record denial requests that are being created. They're loading those into large language models. They're parsing that apart, and they're saying it did or didn't meet the criteria for medical necessity or level of care or this specific DRG, and we're downgrading it. And so we're seeing this increase in the clinical validation type of denials that are troubling for providers because they don't have coders and nurses sitting around with the time or the ability to review, clinical documentation in detail, pull out the evidence, compose a letter, submit the letter, follow up on the letter, and carry that all the way through the process. So it's troubling in particular because it's not just fixed coordination of benefits, we had the wrong payer or missed an element on the thing. It can be done by a business office person by training, but you need clinical knowledge. So you need coders and nurses. And the cost of the availability of those resources is low. The cost of those resources to do that work and the amount of effort it takes per unit of work if you're resolving a denial or a claim is low throughput. So you've got high cost input, low throughput, lack of resources. And in fact, the payers are somewhat betting on the fact that you just don't have them and you're not going to respond. And so you will take that, downgrade because you're not going to chase the delta between what was paid and, the potential original bill DRG. So that's the troubling thing we're seeing, especially in the past, call it 18 to 24 months, is a pretty material increase in these clinical denial types and those coming back. And then even increasingly troubling is the fact that they're doing them in a post-payment review audit type of process, whereby it's not coming in a normal CARC ERA posted code identifiable easily. This is medical necessity. Rather, it's hey, we requested medical records, then we reviewed it, and we decided your 871 is going to be downgraded to an 872, and we're going to pay you, not 16 grand, but 9 grand. And now you got to make a decision with, do I go chase that 7 or do I worry about the next full zero pay denial? And because I've got to use the same resources to tackle both. And that's the troubling part where we're seeing it. It's not a human solvable problem, but we need technology and automation on the side of the providers, be it, I don't care if it's Epic and their, at least appeal drafting capability right now, or some of the other vendors out there that are deploying technology that can parse through medical record documentation and then produce these letters in a more efficient way. That's the troubling trend we're seeing in the market right now.
Thanks, Jim. And moving on to our next question, how are you being more proactive about denials? Can you give me an example? And Keisha, can we start with you?
Yes, absolutely. For our organization, we really are taking a more proactive stance by just our regularly reviewing and identifying the current trends in our denials, as well as just monitoring the requirements and the changes from the payers. That's the big thing. By really implementing and targeting like countermeasures, we really are trying to proactively prevent that first pass denial. We also hold consistent meetings with our denial analysts and our business partners, really to help us gather just the essential data and the trends, which we then use to update any education, any workflows, and any processes. And I think we'll get into this a little bit later, but additionally, we then take that information for any workflow enhancements, right? Like what can we do as far as technology or anything with our EMRs to address these issues up front, and to help ensure like any potential denials are caught prior to the claim submission.
Thank you, Keisha. And how does that align with what you're doing at Mercyhealth, Brad?
Yeah, a lot of what Keisha said, we're doing. We use Epic and Epic Workbench, things like that, to evaluate our denials, and then kind of stratify that by payers. But just because my history is on the managed care side, it's all about getting it into the contract prior to us even having it as a denial. That's really where I'm focused. But there's a lot of collaboration between the revenue cycle, managed care. It's one team at the end of the day. But three things that are extremely important that I think, regardless, it's really difficult to get any language in these BUCA payer contracts any longer. They're very focused on making sure that they don't spend one more dollar of operations in managing their contracts. But there's a couple things that I always suggest. If you have to lean on a couple items, it's better to have at least a few of these things in every contract, and that's material financial impact. That is one piece of language that every contract needs to have. And what that's saying is, payer, you can go do what you need to do. We're going to go do what we need to do. But if you're materially impacting the relationship somewhere in between the signature of this document and the next time we renew, we got to have a platform that we can come together and talk about that. So that's that material financial impact language that's so important. The other thing is some sort of AR protection. Is your denials, is your medical record requests, is your clinical reviews, all of these elements that drive up our AR. Is there a way to have some language that keeps that AR under 90, under 120, whatever your organization's targeted at, under a certain percentage, so that you're not worried about, hey, my major payer, the AR over 90 has grown to 30%. Now, what are you going to do? Your cash flow, and you're talking now to CFOs about what you're going to do terming that payer. So that's very important, but that is a very difficult one to get in contracts. And then I'd say the third one, really, if you can have JOC language, Joint Operating Committee language in each contract, that is very important, because at least then they have to sit in front of you on a monthly basis or quarterly basis and at least talk to you, face to face, or, obviously we use Zoom, Teams, or whatever programs we're using in order to communicate with each other. But at least you're having that dialogue, and it's not hiding behind the veil of a contract or some sort of a technology. You're having to come to those meetings, and you're having to relay and talk about, why did you deny this? This is not inside your policy. You shouldn't be denying this. We notified you within time. Why is this one outside you have ASO clients. Well, those ASO clients still have to abide by this contract. So I would say those are the three main reasons we get. We try to stay upfront in combating some of these denials.
Great answer. Thank you, Brad. And Jim, do you have anything to add?
Yeah, what they said in addition, I mean, the root cause analysis and the trending and proactive tracking, I think it is important to be closely partnered with your managed care colleagues to get these in and try to get at least some leverage within your agreement to prevent, the high number of medical records requests that they're doing, whether they be for audit purposes or some benchmarks and standards. I think one of the questions raised in the chat too was the variation that occurs in terms of standards through which they're measuring medical necessity. Is it Milliman? Is it Interqual? Is it a HEMA Actus? Are they using Sepsis 253? Are they using their own sepsis standards? A lot of those things, feeding that information back to the managed care group so that they can get those in the agreements. Not that they're not going to deny you, but at least you have the opportunity to leverage some language when it becomes a trend and a pattern where you can stop egregious behavior, I think is important. One other thing we're recognizing is being able to using large language models to parse these clinical documents, understanding what is our strength of case for those clinical arguments. They're going to do it anyway. The thing you want to be working with your providers on is improving the clinical documentation. So feeding that back to the CDI and teams to make sure that we are documenting as appropriately as possible and at a granular level and to the best of our ability, following the requirements and the rules with which they're measuring us. Not, again, that they won't deny, but we'll have a better strength of case to argue, no. In fact, this was medically necessary, and it was this level of care that was needed, and it was this bed type, and it were these things. And so bringing that information back to the point of clinical documentation is also hugely important. Again, not that it's going to stop it, but it will give you a better overturn rate when you have to respond to them.
Thanks, Jim. And we'll move on. How are you using AI in denial management? Are you seeing better results in predictive analytics on the front end or in automated appeals on the back end? And we'll stick with you, Jim. What are you seeing across the industry with your clients?
Yeah, we acquired a company back at the end of 2023 that was had built a large language model-based platform that took unstructured data, structured it, and produced a generative output. And our goal in doing so was to begin to replicate or at least improve the efficiency through which we were writing these clinical appeal letters. So how can you take a 500-page medical record document, allow the machine large language model to parse it apart, to find the clinical evidence, to compare it against care guidelines, coding guidelines, payer policies. So the relevant measuring stick for was it right or not, so that you can craft an argument and get that back in a comprehensive way and in an efficient way. I mean, again, you can't cover all the denial types seemingly as they continue to change, but you can certainly create significant efficiency in the work that the humans are doing and reviewing and drafting those letters and sending back a more compelling case. And in doing so, we've seen about a 25% increase in the overturn rate, which has been awesome and huge to see. In addition, we've seen 40 days less from time to placement to payment, just for the fact that the ability to produce those letters is far more efficient. And when you've got, again, a high cost resource that can only, review it takes them a week to review a 500-page medical record and pull all the evidence out, where the machine itself can parse that thing and at least highlight the key evidence sections within whereby the document can be created by the human. Just those steps alone drive efficiency and allow you to touch more of those accounts that are lower dollar in value and were seemingly untouchable before because you didn't have enough resources and enough time and the cost was too high. So you kind of let them go and things like that are more partial denial related, where they're not saying, I'm not going to pay you, I'm just going to pay you less. And it's that kind of death by a thousand cuts where the technology is hugely important. And I implore our clients, I'm like, use all the technology you can, whether you're using it in-house and using Epic or some other tool. I don't care what it is. Use something, because they are. And if you're going to try to keep pace, you're not going to be able to do it by throwing more bodies at it. So we've been on that journey here for some time and seeing some pretty good results.
Thanks, Jim. Interesting stuff. And Brad, you mentioned this specifically too earlier about payer use of AI and how that has kind of impacted your denial rates at Mercyhealth. So how, Jim is saying we should be using all the technology. Is that something that you're doing at Mercyhealth? Are you using all the technology? How are you using it?
This was a good follow-up question to my revenue cycle team. And, they have begun to use AI in order to actually get into the payer portals, evaluate the denials, and then use AI to help create those letters, kind of like what Jim was referring to, is instead of scrubbing 500-page medical records, using AI to pull out those important pieces that the payer was denying for some clinical reasons or whatever reasons that they were being denied for. And Mercy Health has been on this journey now for a short time, but probably not as long as some of your larger systems, but we're starting to see some pretty good results. We don't have a big combination. I don't have a scorecard to be able to share with you, but we are finding we're having good results. We're finding that the information is consistent versus having one individual writing a letter one particular way, and then you write we're finding success with the payer on how to write that letter, and then using that same consistent pattern to redevelop that letter, put the information back in their portal system, and then have that return to us, and ultimately an overturn of a denial or some sort of a payment consideration be made. So Mercy Health has been on that journey now for a little bit of time, and we're finding some success from that.
Great. Thanks, Brad. And Keisha, what kind of AI tools are you using in the authorization space at Wellstar? Are you seeing results there?
Yes, this is our favorite topic, hot topic amongst all of the departments. We talk all the time. And I, just personally, I just really feel that AI and just machine learning really are driving significant advancements just in healthcare and the revenue cycle realm. And it's helping streamline both the front and back end operations. And really what, our presenters were sharing, that just to enhance the accuracy, just the efficacy, and just the overall patient experience as well. And I think in the front end, that the AI powered bots are really increasingly used for. We use that a lot for our real-time eligibility and benefits verification. That's been extremely helpful. These tools just automatically check the insurance coverage and benefit details before services are rendered. And that really does reduce a lot of manual errors, and also in preventing any downstream denials due to eligibility. And many EMR systems now, too, as you were speaking about Epic, they now integrate automation features that really guide the staff through the registration process as well, and flagging any missing information and helping ensure that all the necessary documentation is collected at the point there at patient access. And these predictive analytics, further support just that front end operations by generating accurate patient cost estimates and just really optimizing the billing process as well. I think on the back end, these predictive analytics and the automation are really transforming our denial management and the collections as well. So the AI models are assisting with analyzing the historical denial patterns to identify those high risk claims and flag them for that early intervention. The automated workflows are helping to really streamline the appeals process. This was shared by generating those appeal letters for us, by tracking those deadlines for us, and submitting the supporting documentation directly to the payer. So the assistance also with our robotic like process automation as well that's widely used for the payer follow-up and the cash posting. Our RPA bots can automatically reconcile those payments and post cash to patients' accounts and resolve any discrepancies with minimum human intervention as well. So these technologies really help accelerate those accounts receivable, the turnover with that, reduce the manual workload, and really enable the staff to focus on those more complex cases that really require the human judgment.
Thanks, everyone. Great answers. We're really flying through our questions here. We're just past the halfway mark of the program, and we got some great questions coming in. But I do want to remind the audience that if you would like to submit a question, please click on the Q&A widget. It may already be open on the left side of your screen. And yeah, please let us know if you have any questions. We'll get to those in a little bit. Moving on to the next question. How important is collaboration between clinical and revenue cycle teams to clinical management? How are you creating accountability among these teams to address the root causes of denials? And Brad, let's start with you.
Yeah, absolutely. Yeah, collaboration is key in the organization. Revenue cycle, managed care. Managed care, we're actually creating some RPA stuff right now as it relates to, digging into payer portals and finding policy changes, and then doing the login, preparing policy changes, and then actually distributing that to our revenue cycle areas. That could be authorization, it could be coding, it could be the nursing audit teams, it could be just scheduling, what's changed. So that's one element of the collaboration and incorporation of AI, is using those bots to help take people out of the equation, better deploy your resources. But some of the other major areas that managed care really has focused in on is really just being that bridge to what the payer's requirements are. So when I started at Mercyhealth, there was a lot of disjointed information relative to the payer's policies. So one payer says, well, I need 48 hours notice, 24 hours notice of admission, and our organization has really done an amazing job from the utilization side, using an electronic means to notify payers if it's an ER member, if it's an observation member, if it's a patient that needs to go to needs to be admitted. Making sure that those payers have that information within their required timeframes. But then there's a lot of payers that they're still on fax, they're still on phone calls, and we're still trying to work with those payers, and usually when you have those type of payers where they're not in that electronic means of notification, we're still having to make sure that our contracts allow us the right time frame and allow us the ability to get that retro auth, because it's a lot of times it's not our fault for those retro auths, and it's the payers. So making sure that our contracts have retro authorization language in there is really important, because without that, the payers may not give you that opportunity to ask for that. And I could keep going here for half an hour, but I would tell you that some of the things that are really important is as revenue cycle teams and leaders in the industry, collaborating with your managed care team before any renewal, before any new contract, is extremely important. So we sit down and we talk to our revenue cycle teams, we talk to our finance teams, we talk to our credentialing teams. We actually get what is your biggest burdens by payer, and then we take that information, we have that, and we're ready to go at the time of renewal, at the time of a new contract. And then what are we going to have to try to accomplish? Is it we just need material financial impact, AR and JOC language, or do we need to go deeper? Is there a consistent pattern where we cannot discharge a member to a skilled nursing facility or to an LTAC? I mean, this is where the payers are getting to that level where you can never discharge to a skilled nursing facility or an LTAC. So what are you going to have to do in order to make that change? And then working with that payer to change the behaviors of certain patients that will need to use those levels of services, and digging through, does this payer require some administrative burden that's just over the top for credentialing? Like, what do we have to do for our credentialing departments? And then you just kind of dig into it. Is our coding departments getting bombarded with silly down codes? And just making sure that we're constantly creating an environment of collaboration, so that we are getting upstreams prior to having to deal with the relationship of that payer for 3 years. And so that is really a lot of what the managed care team is doing. My managed care team is doing is creating what we call wish list language. So we sit down with every one of these areas, from revenue cycle, finance, credentialing, and utilization, and we create wish list language. And then that's at the start of every renewal. I mean, granted, we're only going to get a small bit of the language that we want, but it's about chipping away at it. It's about getting a little bit of something every time you talk again at that renewal time.
Great, thanks, Brad. Keisha, how are you kind of encouraging clinical collaboration in the authorization space at Wellstar?
Yes, Brad shared it. That is key. It's extremely important. We have monthly denial meetings, and those are really organized too by service lines, and we ensure that we have representatives from all of the key areas. So we have operations there, we have coding, a representative for authorizations, and the providers, and they all participate. And we go through and we actually review our denials, and we engage in in-depth discussions about the root cause of the denial. So in these sessions, again, they focus on identifying what can be our countermeasures and developing actionable plans to really mitigate these denials going forward. I also want to add that, like, our analysts as well, they play a very critical role by sharing, again, those denial trends, and providing specific case examples. When we have those and we review those in our denial meeting, we share those with our responsible leaders. And that enables the leaders as well to really educate their teams. It really does foster accountability and ensures that the lessons learned are translated into improving the processes and our outcomes. So by having this structured forum for cross-functional collaboration, if you want to say, we really can address the root cause of the denials more proactively and really drive for that continuous improvement across the organization. I think you went out. On my end, I think you went out.
Did we lose you, Luke?
Yeah.
My apologies. Technical difficulties. We always have at least one. Jim, as you're working with clients, do you notice a difference? How much does collaboration with clinical teams matter when it comes to denial management?
More so than ever, is what we've seen. I mean, the denial trending by root cause, by underlying process breakdown, those kind of things, super important. I think everybody's doing that quite well in the industry now. We tried to bring back also, look, is it just us, meaning just you, the organization, or is this a broad-based pattern by a given payer? So how are we comparing against our colleagues and cohorts in a given region, a given market with the same type of payer mix? Are they seeing in turn the same number of sepsis denials? And allows us then to isolate, what is the underlying reason? Is this a pattern across the board, or is this something we could affect internally to improve? And one of the things we've realized as we've automated a bunch of the denial letters, as I mentioned, around the clinical denials, is a thirst by, most of those are moved from the back end of the revenue cycle back into the mid cycle where the clinicians exist, and and CDI, and those folks, get the responsibility for pulling the clinical documentation and reviewing it and writing the letter. And they were like, this is great that you can help us automate the letter creation. But one of the, kind of exhaust outputs we get of doing that work, which our nurses and coders don't love, but is reviewing that that clinical documentation against those rule sets to understand where deficiencies, again, exist in our clinical documentation. And is there, do we have a higher number of sepsis downgrades for Dr. Jones on the med surg floor, or where does that exist? Where can you help us identify where, if we improve that documentation, again, not that they're not going to deny us, but that we'll have a better strength of case if we document it more appropriately or in a different pattern? How do we do that? And so we've spent a lot of time unpacking, giving that data back to our clients to say, hey, look, if you do a better job for these specific denial types and this condition, these DRGs specifically, we'll have a better chance of overturning them collectively, and giving that information back. So it's getting down, a couple levels further into what's the supporting documentation ultimately that goes into that letter. I think then it goes back to then feeding that also back to Brad and teams. What kind of language can we get in our agreements that say, hey, we're all going to collectively agree that sepsis 2 guidelines is what we're going to measure against, and attempting to get an agreement there. Again, it varies so widely when it comes to sepsis, which is one of the biggest reasons for downgrade. I think one of those questions was raised. Who's measuring against what? And we'll get clients saying, well, that's not fair because so-and-so is an MA plan and they should be following CMS guidelines, which suggest that it's sepsis 2 guidelines. It's like, okay, well, that's a Brad issue because he's going to need to go argue that with the payer. We can't affect that. We can argue whatever you want to argue. We can point to 2.253 and make that case, but that's a policy and a managed care agreement kind of issue you're going to have to go solve for. So anyway, it's digging into that information, providing that level of granularity, and asking yourself again, what can we affect versus is this a pattern more broadly with the payer and their behavior? And do we need to then take that back to our friends in managed care and have them have that discussion at the negotiation table?
Great. Thanks, Jim. We are getting some great answers, or great questions from the audience, great answers from our panelists. Because of that, though, I'm going to have to skip through some of our scripted questions. I'm going to move on to our last scripted question, which is, looking ahead 1 to 2 years, do you believe that the challenges around denials will grow or recede? What trends lead you to that conclusion? And Jim, can we get your answer first, please?
We're edging toward the battle of the bots, where two large language model platforms with established rule sets are arguing amongst each other by trading information back and forth in the form of a letter or some other format. So we're inching towards that, it seems, day to day. And so again, I think kind of the Hatfields and the McCoys are both arming up in different ways. I would suggest the payers are arming up faster with their deployment of technology than the providers are. They're better capitalized, they're more consolidated, they got more capacity and sometimes capability to do it. And so that's challenging for sure right now across our provider clients. And that, like I said, I would highly recommend looking at different technology solutions, and it doesn't need to be one, and or partner with organizations that are investing in technology to try to even the playing field, and using that as an interim until you get to a deployed technology that can help you kind of automate some of this process. I mean, we collectively have to take this waste out of the system and not do this back and forth all the time. It is just burdening the whole industry and our whole economy. And so, the question will be, how do we do that, and where does this thing break? I think we're on a collision path for that happening, and it's going to need to be a technology solution, in my opinion, where you can establish the rule sets between the two, you can exchange the level of detailed information needed to justify the case, the complexity of the case, the severity of the case, and the resources that were used to treat that member or patient. And you can settle that out without this back and forth, round and round fighting between the two. I'm hopeful in the next, call it 3 to 5 years, we're finding a better balance between the two. in some form or fashion.
Thanks, Jim. Are you hopeful, Keisha? Jim ended his answer with a bit of hope. Or do you share that hope?
I do. I agree with Jim. And I really do think that it really is dependent upon the organization as well, like where you are with your use of AI and machine learning. I just think that as as we just continue to explore and expand within the scope of AI and the machine learning, the need for team members to focus maybe solely on just the denial management, I think that may diminish over time, and that we will be able to utilize those team members in other areas that may need human involvement. But as we stand right now, who knows?
Maybe Brad knows. We'll let you close us out on this one, Brad.
I don't know. However, what I would tell you is, just the years in this industry and how thick those payer provider manuals are. There hasn't been enough people on the payer side to audit that everything is working. And I think what we're going to find in the next 1 to 2 years is far more denials, because now we're talking about machines and we're talking about computer aided validation and audits versus people that used to have to go through there and validate that. And so what I think we're going to find is we're going to find a lot more. We're going to see a heightened denial growth. And I think that the providers are going to have to come at this with as much aggressiveness as the payers have historically. And the providers, I think, historically have tried to incorporate people and processes, but I think the technology side is really going to have to start to grow in order to kind of come after this. Because I sit here with contracts today where I have payers that they're not implementing their own rules because they didn't have enough audit capability in order to validate if they were not paying or paying us appropriately, or if we did something wrong relative to their policies. But I think if they can put automation and AI to all of those policies, then we're going to have to quickly figure out how to combat that, or we got to get right at it really quick, so that we don't have those denials. So that wasn't a very good ending to the panel questions, but I don't think it's going to get easier. I think it's going to get a lot harder. But I do hope for a 5-year approach, like Jim was talking, where we all have a say in the best approach to take care of people, because at the end of the day, that's what this is taking care of people in your communities and what we care most about. And I hope that there's enough say between the collaboration of a payer and the providers that we say this is the right thing, and we can go with these rules, and let's maintain and follow these rules into the future.
Thanks, Brad. Thanks, everyone. I really appreciate the discussion. We flew through some of those questions, and we are going to move on to, with about 10 minutes left, some of our audience questions. The first question is for Brad from an auditor working in denials. Payers are using clinical criteria beyond that required to validate a diagnosis. Any suggestions, or what do you think the payer is thinking when it comes to clinical validation denials? Any suggestions for hospital systems dealing with this problem?
That question is a very good question. What I would say is, a lot of times the medical record and what the physicians documented sometimes doesn't always describe what the payer's denial necessarily is going after. And so having those discussions with the payer around, what are you looking for here? Is there a particular element of a surgical note that you're looking for? And really having that discussion to see if there is information in the medical record, there is information that was supplied to the payer to remove or reduce that clinical denial. That's the pieces. Now, if we're just talking that the payer's interpretation is always going to be skewed to what was delivered from care, then really where that has to go is creating a level playing field with that payer to say, okay, what you are denying is unfair to really what you are to what we're providing, and then finding where you need to attack that, either from a contract perspective. And I always say you have to sometimes create a problem to have something to fix. You might have to create a problem, and that and problems do occur in our world, and you might have to grab your legal team to start rewriting something and get that second level of support around, hey, our physicians provided those clinical services, and you can't just say that those services didn't happen.
Thanks, Brad. Keisha, we have one for you. You had mentioned your use of bots for posting cash and resolving discrepancies, and we have an audience member just asking us if you could explain that a little bit more, or explain it again.
Was that about the robotic process automation? It's just in the industry, it's known as RPA, and there are some organizations that use that a lot for their payer follow-up. There's multiple AI vendors as well that have the ability to utilize their bots or AI to call and do the follow-up for them, as the payer follow-up for them, as well as cash posting that may be available.
Great, thank you. We have another audience question. This may be directed toward Brad. We have an issue where even if we have the language in the contract, it still falls back on the facility to have the time and resources to monitor and hold payers accountable. How are you kind of finding the resources to do this, Brad or Keisha? Or Jim, if you'd like to share how your clients are finding the resources to do this. Any takers?
I'm never at a loss for words, so I don't mind sharing what we do. I apologize if I'm talking too much. We have an underpayment team, and generally that is an underpayment team that goes after our PFS areas, denial management side. And we're validating every payment that an insurance company makes to us to our contracted expected. And so because we have that connection between the expected reimbursement and what we were paid, we're going through there and validating. Okay, so when you go back and you do that validation, then you go back to the contract itself. And what does that contract say? So if the contract says you have the ability to request underpayments, let's just say, most payers are going to go for 90 days, 6 months. And in every one of our contracts, we're trying to make 12 months to 18 months a minimum for us to go recover our underpayments. And so essentially we call that an underpayment. And then we go after whatever we're being denied for, and we use our contract language from that point forward. So really what I would tell you is it's being able to identify when you're not being paid appropriately, and then using your contract to back up that the underpayment or denial.
Great, thanks, Brad. We have another question here. Some denials are the results of egregious behavior by payers to not pay. These are sort of erroneous denials, I guess. Do Mercy or Wellstar include in any way financial penalties? Is there a way to include financial penalties on payers for these erroneous denials?
I can speak for Wellstar. I'm not certain of that. That is a great question. That is something that we would have to really check with our payer relations team about, but I am not aware of that. It's a really good question.
Is that something you're familiar with, Brad?
So a lot of times what we'll do is, obviously the cost of doing business is going to go up if the payer makes us fight for the reimbursement more than we had to. And so if we look at the amount of effort to get paid, well, then their reimbursement or their yield relative to their competition is going to have to go up relative to the market as well. And that's one of the ways that you would make a payer pay for erroneous and egregious denials. The other thing that you can do is, look at your state and what does your state have out there that's been regulated on the fully insured side. ASO is a little bit harder because you're talking about ERISA business, but in the fully insured side, so anything that's fully insured that's state filed, look at those clauses in the state and then start to use those clauses back to that payer and say, hey, this shouldn't have been denied. And oh, by the way, I have 11% interest when I was in the right and you were in the wrong. So we either have to figure out a way to come together here to stop these denials, or I'm going to have to go fight for an additional 11%. And I use 11% because it each state's going to be a little bit different, but let's just say the number is around that.
Thanks, Brad. And we have one more question. We have several more. We're only going to get to one more question from our audience, and that's for Aspirion. Does Aspirion work with home health providers?
Not today. Not today. We are focused on the majority of our clients are the large 500 million net patient service revenue and greater health systems. And again, a lot of our investment has been around both resources, so 100% onshore resources focused on these niche areas of the revenue cycle that take specialized knowledge or technology. So be it those clinical denials that require, we had at one point 180 attorneys and 90 clinicians, all US based, that were doing clinical validation denials. And so those high dollar, very well trained, very knowledgeable, expensive resources, just by nature of the volume of accounts and the dollar balances we're going after, support folks like Wellstar and Mercy as a supplement to their existing staff where they can't hire enough, don't have the right expertise. And again, that can be in places like MBA and workers' comp and other things that are rules-based as well. But that's where we're spending our time. Ultimately, I'd love to get into those other ancillary markets where a lot of the business is going, but we're not there yet.
Thanks, Keisha. Thanks, Brad. Thanks, Jim. Really great discussion. That's all the time we have for today. In closing, please note our next Winning Edge program on February 10th will cover the Winning Edge for recruiting the best nurse team. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week for continued coverage of defeating denials by visiting our website, healthleadersmedia.com. Thanks again to our panelists for an excellent discussion and our sponsor, Aspirion, for making today's program possible. And finally, thank you to all of you in the audience for participating. We hope you enjoyed today's program and look forward to seeing you during our next Winning Edge program on recruiting the best nurse team. Thanks again, everyone. Really appreciate it.